Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to the 7th webinar in the Women's Health 2024 series. Today's webinar is titled Polycystic Ovarian Syndrome and Cardiovascular Disease, featuring Dr. Licy Yanes Cardozo, Professor of Pharmacology and Medicine at the University of Mississippi Medical Center. Today, Licy will present the heightened cardiovascular risks associated with PCOS, the mechanisms underlying these risks, the current treatments available, potential new therapies, and the existing knowledge gaps in women's health research. Before we get started, I'd just like to acknowledge our partners for this series, the American Physiological Society, the Society for Women's Health Research, and Scientist.com. We'd also like to say a very big thank you and give a shout out to all of our series sponsors. None of this would be possible without them. I'm Sarah McFarland from the events team here at Scientist.com, and I'm very happy to be your host for today's event. Before I welcome Licy to the floor, I wanted to cover a few housekeeping notes to help you get the most out of your experience today. First, take a look at the interactivity panel at the right of your screen with 4 tabs: Chat, Q&A, Polls, and Handouts. This is where you'll participate in the Q&A as well as access all webinar resources. We want this to be an interactive experience for you, so please send your questions, thoughts, and comments to us using that Q&A tab, and we'll try to address as many questions as we can at the end of the webinar today. You can also explore some links in the Handouts tab to learn a bit more. And lastly, if you're having any technical issues, please try refreshing your browser and ensure that you're using Google Chrome to access this event, as it is the most stable browser. If you're still having trouble after you refresh, use that private chat function to communicate with me, and I can help you to troubleshoot. And now I'm very pleased to welcome Licy. Thank you so much for being here, Licy, and take it away whenever you're ready.
Thank you so much, Sarah. Good morning, everyone. I'm so excited to do this lecture today. So this is the outline of my talk. We are going to discuss at the beginning the cardiometabolic complications that are associated with elevated levels of androgens in female rat. The middle part, we'll talk about mechanisms and then and possible therapeutic options that we have in the clinic to treat these women. And then at the end, we'll share our data with clinical research in women with PCOS and racial disparity. So I'm a practicing endocrinologist. I am physician scientist here at the University of Mississippi Medical Center. So I'm going to be sharing with you cases of patients that we evaluate in the endocrine clinic. So the first one was a 30-year-old woman who presented for evaluation due to excessive hair growth. We call that hirsutism, and irregular menses. So she had this since she went through puberty. And this is classic to hear from patients who suffer from PCOS. And also she told us that her symptoms worse after she gained weight. Her physical exam was positive for elevated blood pressure or hypertension, 140/98. She has obesity. Her BMI was more than 30. So her BMI was 38, and she had hirsutism on physical exam, and her lab work revealed an elevation in both her free and her total testosterone. So we made the diagnosis of polycystic ovarian syndrome, PCOS, and the question that we will answer together is what are the mechanisms that underlie these increases in blood pressure and obesity. So polycystic ovarian syndrome is the most common endocrine disorder in reproductive age women, with a prevalence of around 10%. So 1 in 10 women have the diagnosis of PCOS. The two problems that we have is that we don't know the etiology of the syndrome, and we really don't have a specific test to use in the clinic to the diagnosis of to make the diagnosis of PCOS. The pathophysiology is rather complex. So we start at the hypothalamus level, where a single neuron will release GnRH, and this is going to be important to understand one of our clinical projects that we had. So GnRH will bind to the receptor in the anterior pituitary gland to release LH and FSH. So LH will regulate the production of androgens by the ovary, but also the adrenal gland. Up to 25% of women with PCOS, the adrenal gland will release androgens, and as well as the adipose tissue. Now we have plenty of evidence that the androgen, the adipose tissue is an endocrine gland, and also can release androgens. So there are few positive feedback in the body. So this is one of them, and it cause it could be one of the main mechanisms of the disease. So high level of androgens feedback in a positive way to increase the amplitude of GnRH release, to increase the amplitude again, to increase, the frequency of the LH release. And this increase in frequency is what release androgens in the ovary. So today we're going to discuss the role of androgens, but I want to point it out that there are two other hormones that they are also implicated in the pathophysiology in the PCOS. So one is the unopposed level of estrogens. So they have this continuous level of estrogen, and that is because they have low level of progesterone. So PCOS is the number one cause of anovulatory cycle. So we see low level of progesterone, and this can unoppose the estrogen. So again, today we'll talk about high level of androgens, but I just want to mention that these two hormones most likely play a major role in cardiovascular disease in this population as well. So these women may seek medical advice from different providers. For example, they can seek medical advice from a dermatologist doctor due to the dermatological manifestation of the condition. So this is the hirsutism or excessive hair growth. They may present hair loss, and this is what we call the androgenic paradox in endocrinology. The same hormone causes hair growth in the face and hair loss in the head. This is an index of insulin resistance. It's called acanthosis nigricans. And acne past puberty is pathological, and it could be a manifestation of PCOS. These patients also may seek medical advice due to the reproductive manifestation of the syndrome. So as I said, PCOS is the number one cause of anovulatory infertility, oligomenorrhea, or less than 8 periods in a month. And this is an endometrial carcinoma. And because they have these elevated levels of estrogen that is unopposed by the low level of progesterone, they have an the endometrial can proliferate. We call endometrial hyperplasia, and that is a risk factor for endometrial carcinoma. As an endocrinologist, my main concern is that these women very frequently suffer from a high prevalence of cardiovascular risk factor. Obesity, up to 80% of women who have the diagnosis of PCOS in US suffer from overweight or obesity. Dyslipidemia, and they have an increase in the bad cholesterol of LDL and a decrease in the good cholesterol of HDL, elevated blood pressure, and insulin resistant and type 2 diabetes. The mechanisms that underline this cardiovascular risk factor is not completely understood. So these women that have a very frequent cardiovascular risk factor, it had been a matter of debate in the past several years whether that will translate in cardiovascular morbidity and mortality. So this paper answered that question, and they look at the risk, the increased risk of cardiovascular risk factor in women with PCOS, and they compare to control women. Um, what they report is that women who have the diagnosis of PCOS have an increased risk of myocardial infarction of about 38%, an increased risk of chest pain or angina, and an increase of 50% of revascularization of the coronary arteries. So these women have a so they have an increase in prevalence of cardiovascular risk factor, and this also translates in an increase in prevalence of cardiovascular disease. But what it really caught my attention is the average age of women with PCOS, that it was only 29. So these are young women that we see in the clinic, and they already have heart issues. We use the Rotterdam criteria. As I said, we don't have a specific test to diagnose PCOS, so this is what we use most commonly in the clinic and in research, the Rotterdam criteria. So we only need to meet 2 of these characteristics to make the diagnosis of PCOS. Elevated level of androgens clinically or a biochemical elevation of androgens. Ovulatory dysfunction, the clinical manifestation is irregular menses, and the polycystic appearance of the ovaries, which, by the way, they are not really cysts, they are follicles. So they have an increased size of small follicles. So we have several epidemiological data that suggests that those women who have the high level of androgens, because we only need 2 of these 3, right? So you have women who have the diagnosis of PCOS and have normal level of androgens. And then you have women who have the diagnosis of PCOS, but their level of androgens are normal. So if you compare between those 2 groups, only these women who have high level of androgens will have this increase in prevalence of cardiovascular disease. So the link or the mechanisms by which this high level of androgens may mediate this increase in risk in cardiovascular disease is unclear. So what do we have in the clinic to treat these women with PCOS? So the number 1 recommendation is weight loss. This is the number 1 intervention. I don't need to mention that this is very difficult to achieve and sustain for many women. Metformin we use very frequently, is off-label to be used in women with PCOS. We use it all the time, but really the effective part of metformin on insulin resistance is very questionable, at least in this population. And other pharmacotherapies, glucagon-like peptide receptor agonists, GLP-1, are getting very popular, and we are going to discuss our findings with these agents. That we believe that this will be the way to treat women who have PCOS and suffer from cardiometabolic complications. So we don't have many options to offer to our women with PCOS. And the other problem that we have is, unfortunately, the experience that women have to go through to finally get the diagnosis of PCOS is rather long and stressful. So this is a study that they based on questionnaires that they were sent to women who have the diagnosis of PCOS, and they asked several questions. One question was, how long you wait until finally you got the diagnosis of PCOS? And you can see here that close to 50% of women with PCOS have to wait more than a year to finally get the diagnosis of PCOS. And this is despite the fact that they saw several health professionals. So they seek medical advice, and almost 50% of these participants have to see more than 2 professional health to finally get the diagnosis of PCOS. So they do have, unfortunately, have to wait for a while before they finally get their diagnosis of PCOS. So the first questions that we ask in the lab is whether the elevated level of androgens that are seen in women with PCOS are the cause of the cardiometabolic complications that they suffer. So this is the experimental model of PCOS that we use in the lab. We use dihydrotestosterone DHT that cannot be that is not going to be able to be converted to estradiol. So it's a pure androgen. We implant this pellet when the female rats are 4 weeks of age. And by using this pellet, we were able to see a 2-fold elevation of plasma androgens, which is what we see in the clinic. And as a result of this, we saw a profound alteration in the estrous cycles of the female rat. So this is a normal estrous cycles that change every day. And you can see this, that this rat receives CHD, have profound alterations on the estrous cycle. So this data suggests that elevating level of androgens mimic well the reproductive characteristic of the syndrome. What about the cardiometabolic complications? So this is the food intake, and 5 days after the HD implantation, we already saw an increase in the food intake, which was significantly. I'm sure you are not surprised to hear that, because they eat more, their body weight went up in the DHD treated rat, And this is the adipose tissue measured by echo MRI, which was increased significantly as well as result of the DHT implantation. In the lab, we also use a micro CT to see which depot is the one that is affected. This is an example of a micro CT. So this is the sub-Q adipose tissue, which is the adipose tissue that is under the skin. And this is the visceral adipose tissue, which is the adipose tissue that is inside the peritoneal cavity. So DHD causes an expansion of both depot, but it's really time dependent, at least to see it in a CT scan. So this is a CT scan, the quantification of CT scan in our model of PCOS after 90 days of DHD. And you can see that we see an early expansion of the sub-Q adipose tissue. With time, the amount of adipose tissue just goes up, and we can see a clear expansion of both the sub-Q and the visceral adipose tissue. So you can imagine that with time, the cardiometabolic complications are better seen in our model. So they gain weight, they eat more, and they also have insulin resistance. As women with PCOS do, their plasma level of glucose fasting is the same. We only see this hyperglycemia after we challenge them with a glucose load. So they have intolerance to glucose. They have an increased level of plasma insulin. The postprandial, they have postprandial hyperglycemia. So that is the glucose that go up after we eat. They have an increased level of plasma cholesterol and an increased level of leptin. So this model mimic well the cardiometabolic complications that we see in women with PCOS. And finally, when we measure the blood pressure by radiotelemetry in this animal model, we saw an elevation of blood pressure of about 10 millimeters of mercury, which is significantly higher compared to this rat that receives placebo. So these data suggests that high level of androgens mediate the cardiometabolic complications that we see in women with PCOS. Now, I'm sure you are thinking that if high androgens are the problem, you can block androgens and you should be able to cure the syndrome. So we cannot do that in the clinic because unfortunately, we don't have a safe and effective anti-androgens to be used in the clinic. So this is a data that was published several years ago, back in 2011, that this is a case series of seven women who came to see the physicians, and they have clinical manifestation of excess of androgens, right? So they were placed on flutamide, which is a specific anti-androgens we use in men who have prostate cancer to block the androgen receptor. So they were placed on flutamide, and look what happened to them. So they have severe hepatic injury. They all require liver transplant, and actually one unfortunately passed. So since this data was published, we have a black box by ADS, by FDA, that anti-androgens flutamide, you can only use it in men. And we have really, we don't use this in women due to this hepatotoxic effect. The mechanism behind the effect of anti-androgens in the liver in women remain unclear. But so we cannot use it in the clinic. But one of the beauty of being a physician scientist is that you can do in the lab things that you can in the clinic. So we try to cure the PCOS model in the lab. So my postdoc, Dr. Torres Fernandez, took the DHD pellet he implanted when the rats were 4 weeks of age, as we always did. He left the DHD pellet for 6 months. And at 6 months, he stopped the implantation of the DHD pellet with the idea to see if we will be able to reverse all the damage that we saw with high level of androgens. And then Edgar follow this rat for an additional 6 more months, and then he did body composition, and also he studied the cardiometabolic complication of this rat. We call this rat XDHD because they have DHD in the past but not longer. So I'll share with you a couple of data that we already published. So this rat that received DHD 6 months after the DHT was withdrawn, they still eat more. Um, as a result of that, the body weight was still elevated. They also have an expansion of the adipose tissue. And then also they still have the insulin resistant. So we call this an androgenic memory. So once you turn on signalings by androgens, then you cannot turn it off, despite the fact that you normalize the level of androgen. And this is very important. As I mentioned, most of women have to wait at least 1 year or longer to get the diagnosis of PCOS. So we think that this is very important. So to summarize the first part of my talk, I show you that high level of androgens are associated with negative cardiometabolic complications in PCOS, and then the withdrawal of hyperandrogenemia really doesn't reverse the cardiometabolic complications that are observed in women with PCOS. We will move to the second part of my talk, that we are going to talk about some of the mechanisms that we are studying in the lab to elucidate the effect of androgens in women. So this is a renin-angiotensin system, a classic system that regulates blood pressure and fluid composition in our body, highly regulated by sex. Steroid, androgens can change it, estrogen can change it. And briefly, this system comes with two arms. This is the good arm, and this is the arms that mediate the negative effect. So when we have an activation of this arm and the AT1 receptor, we see high blood pressure, renal injury, so negative cardiometabolic effect. But when we see an activation of the protective arm, we see vasodilatation. So we see good things in the cardiometabolic system. So several years ago, we published that some of the components of the classical renin-angiotensin system were upregulated in the kidney. So this is the angiotensin converting enzyme, is the enzyme that converts angiotensin 1 to angiotensin 2. So the expression of this enzyme is upregulated both in the cortex and in the medulla of our PCOS model. The angiotensinogen, this substrate that you have here, angiotensinogen also is upregulated in both in cortex, in the medulla. So the increases in blood pressure that this rat has is renin-angiotensin system mediated. So we measured the blood pressure in the placebo rat. We saw the 10 millimeters of mercury of increase in the rat that received DHT. These rats are not salt sensitive, and we gave them an angiotensin converting enzyme inhibitor, enalapril, which is the one that we frequently use in the clinic. And we were able to see the decrease in blood pressure, suggesting that the activation of the renin-angiotensin system mediate the increases in blood pressure. We also use an endothelin type A receptor blocker, and this we didn't see any changes in blood pressure. So these data suggests that activation of the renin-angiotensin system mediate the increases in blood pressure in our model, and not only in presence of hyperandrogenemia. So we measured the blood pressure in the XDHT rat, those rats that receive androgen for 6 months on and off for 6 months. We saw that the blood pressure was still significantly increased, and then when we gave the rat enalapril or an ACE inhibitor, we were able to abolish the increases in blood pressure. So activation of the renin-angiotensin system persists with time, even in absence of hyperandrogenemia in our model. I'm going to show you a couple of genes that we measured in this XDHT rat, and particularly it seems that the kidney medulla are the ones that are going to be the ones that are responsible for these increases in blood pressure. Angiotensinogen remain elevated in the kidney medulla, AT1 receptor remain elevated in the medulla, and as well as the androgen receptor was still elevated in the medulla. So we believe that the kidney medulla is a key place where high level of androgens act and are the reason why the blood pressure remains elevated even in absence of androgen. And we call this phenomenon an androgenic memory. So more recently, we repeat the experiment with ACE inhibitor, but we also gave ACE inhibitor to a control group. So we saw, again, the significant decrease in blood pressure in rats that receive DHD, so androgen-mediated renin-angiotensin system activation, androgen-mediated. So we saw a significant decrease in blood pressure with enalapril. But what we were really surprised is to see that the co-administration of enalapril with DHD was able to completely abolish the expansion of adipose tissue that these rats have. So the red are the PCOS model, and as I mentioned earlier, this adipose tissue just get larger with time. But if you give enalapril at the same time than the DHD implantation, we were able to abolish the expansion of the white adipose tissue. So this data suggests that the presence of angiotensin 2 is necessary to have this expansion in the adipose tissue. We measure the insulin resistance because the adipose tissue, we were able to completely abolish the expansion of the adipose tissue. We wanted to see if this will result in an improvement on insulin resistance. And unfortunately, we did not see that. This is the HOMA-IR, which is an index of insulin resistance. The HOMA-IR index is elevated in androgens, and the administration of enalapril was not really didn't lower this level of insulin resistance. And this was the first piece of data that make us think that insulin resistance does not parallel always with an expansion of adipose tissue in presence of high level of androgens. So this is data from one of my medical students, Logan. So Logan asked the question whether the renin-angiotensin system is differently regulated in the different adipose tissues. So we have the sub-Q and the visceral depot. And what Logan saw was that the ACE enzyme is upregulated in both depot, in the sub-Q and in the visceral, as we found it in the kidney. But what it was very different is the effect of androgens in the ACE2. Remember, this is the compensatory arm of the renin-angiotensin system. So the sub-Q was able to mount a compensatory mechanism here with an upregulation of the ACE2. So you have the bad and the good one upregulated at the same time in the sub-Q. But what he observed is that when he measured the good one, the ACE2 in the visceral, he didn't see an upregulation. So the visceral adipose tissue may share the same deleterious effect, but the compensatory mechanisms of the visceral adipose tissue are very different. And currently we are doing more studies to fully characterize the renin-angiotensin system, both arms in the adipose tissue. So stay tuned. So activation of the renin-angiotensin system is also seen in women with PCOS. So this is a paper that was published recently by Dr. Stackenfeld group, that what we did together is we analyzed the role of the sympathetic nervous system in women with PCOS, and as well the renin-angiotensin system. So these are women with PCOS, and this is the systemic renin-angiotensin system, some components, right? But what I want to point out your attention is to the ACE level in the plasma. So women with PCOS have, as our animal model of PCOS, they also have high level of ACE, of the deleterious arm of the RAS, compared to the control group. These are the control. So women with PCOS have high level of ACE. And this is the effect of their intervention to analyze the activation of the sympathetic nervous system. But I want to point it out your attention what happened to the ACE inhibitor once these women receive an anti-androgen, which act centrally, is a GnRH antagonist. So these GnRH antagonists really suppress the GnRH, so they don't have testosterone. So as you can see, the administration of the blocker was able to decrease increase the level of the ACE in these women furthermore, suggesting that this elevation of ACE are also androgen dependent in women with PCOS. So to summarize the second part of my talk, I show you that androgens mediate the increases in blood pressure, and this is due to an activation of the renin-angiotensin system. The intra-adipose RAS could be implicated in the androgen-mediated increases in blood pressure, but not the insulin resistant. And insulin resistant in PCOS seems to be independent of obesity in PCOS. So as I said, one of the beauty of doing basic research is that we can answer questions that we have in the lab, in the clinic. We can answer them in the lab. And one question that we think that is very clinically relevant is how we are going to benefit women with PCOS and how well our interventions perform in clinic. So I'm going to share with you data of two interventions that we have available for women with PCOS. So the first one is weight loss via caloric restriction, and the second one are GLP-1 agonists. So we ask the question, whether these two interventions will be able to ameliorate the cardiometabolic complications that we see in women with PCOS. So this is the body weight data. So the rats that receive DHD gained weight with time and compared to the placebo, and in green are the per feed. So these are the rat that receive the same amount of food intake than this placebo. So you can see that the increases in blood, increases in body weight was attenuated in these rat that they were per feed to the control group. And this is the data about the per feeding. So you can see that the green line really match the blue line. So the rats that received DHD, they were per feeding with the control group. And this is the cumulative food intake. So elevated in the rats that received DHD, control and per feeding rat received the same amount of food intake. So what did we see within the adipose tissue? So we measured the adipose tissue by echo MRI. As I showed earlier, the adipose tissue gets expanded with time in the rats that receive DHD. By per feeding then, we were able to abolish the expansion of the adipose tissue. Lean mass also goes up with androgen as well as the adipose tissue does increase with time. So the lean mass went up, and these rats that were per-feeded, we saw an attenuation of the lean mass compared to the rats that receive DHD and ate ad libitum. What about the blood pressure? So by per feeding, we were able to normalize the blood pressure increase in our rat model of PCOS. So weight loss by caloric restriction abolished the expansion of the adipose tissue and the increases in blood pressure. We are in the process of measuring more component of renin-angiotensin system, but this is the one that I want to share with you today. The plasma angiotensinogen is up in our model, and it was attenuated by these rats that were per feeding, suggesting again that the intrarenal the intra-adipose tissue, the intra-adipose renin-angiotensin system could be implicated in these decreases in blood pressure that we see in rats that they were per feeding. So this is a case, as I said, weight loss is the number one intervention that we give to our patients who come to see us for PCOS. So this is one case that I want to share with you. So a 30 years old woman that came to the clinic with inability to lose weight. So her body weight, she weighed 261 pounds in the initial visit with us. And you can see here both her free and her total level of testosterone. Her free testosterone was elevated and her total was in the upper normal range. And this is something that we see very commonly. So that's why we have to measure both the free and the total testosterone, because the free can be elevated and the total level of testosterone can be in the normal range due to the changes in the sex hormone binding globulin. So here at UMC, we use EPIC, that's our electronic medical record system. So EPIC tell you when it's abnormal, and then it tell you if it's elevated. So her free testosterone was elevated, and then so she went home and she lost 20 pounds following lifestyle intervention, came back 6 months later, and you can see that her free level of testosterone went back to normal, and 50% reduction in her level of testosterone. So remember, the adipose tissue is an endocrine tissue that can convert androgens. So there is an enzyme, the 17 beta hydroxysteroid type 5 dehydrogenase, and this enzyme can activate androstenedione or a pro-androgens to the active form of androgens, which is the testosterone. And this enzyme actually is elevated in women with PCOS. So there are many women that the syndrome, the high level of androgens, is really a consequence of the expansion of the adipose tissue. And in those women, weight loss is very important. But going back to our bird feeding, we were able to abolish the increase in blood pressure. But what happened with the insulin resistance? So these are the plasma glucose levels in the 3 groups, and look what happened with the plasma insulin. So our PCOS model have high level of insulin or hyperinsulinemia because they are resistant to the effect of insulin. But the pair feeding actually have even further increase, higher increase of the insulin, suggesting that by pair feeding, we are able to abolish the increases in blood pressure, but we were not able to abolish the insulin resistance. And this experiment was the second one that gave us the idea that really the cardiometabolic complications that we see in PCOS they really have different factors that mediate. So it's not going to be a simple mechanisms that will explain all the deleterious effect. What about metformin? We use metformin all the time, right? Off label in women with PCOS. So we gave metformin to our animal model of PCOS. So this is a body weight. And unfortunately, metformin didn't do much with the body weight in our animal model of PCOS, and didn't do much either with their insulin resistance. So this is what we suspected for years in the clinic, that we use metformin all the time, but it really doesn't live to the expectation that we have to this drug. So metformin works is an insulin sensitizer. So perhaps the presence of high level of androgens blunt the beneficial effect of metformin. And that's exactly what we show in this paper that we did a collaboration with the Mayo Clinic. We analyzed the data from all the patients that seek medical advice at UNC, and we analyzed the factors that mediate the metformin failure, which it was very high. 43% of all the patients that receive metformin have metformin failure. So these are men and women, right, with type 2 diabetes. I want to make that acclaration. So 50% fail to metformin. But look at this, the sex male, being a male, was one of the risk factors to fail metformin. So really perhaps the high level of androgens mediate part of this metformin failure that we very frequently see with women with PCOS. What about GLP-1? They are getting so popular now, a weight loss medicine that is FDA approved for type 2 diabetes and also for obesity. So we asked the question whether these GLP-1 agonists will be a good choice to use in our model of PCOS. So we all have GLP-1 in our system. It's liberated by the GI tract, and it will act on several organs to mediate beneficial effect. So it will have actions in the brain to decrease food intake. It's good for the kidney. It's good for the adipose tissue. GI doctor love now because it improves liver steatosis. The side effect, it really decreased the motility of the gut. So unfortunately, we can see nausea and vomiting with this drug, but overall, several beneficial effects. So we test the hypothesis that this drug will be a good thing to use in our animal model of PCOS. In this time, we wait until the PCOS rat has 17 months of age, 17 months old, and then we gave them the liraglutide of this is a daily GLP-1 agonist, and then we gave the agonist for a month, and we did body composition and metabolic parameters before the drug and after the drug. So this is data that is published. I'm going to show you just some of the key findings. So the food intake increased by DHD. This is the data that I use a lot in my clinic. Look, this is the effect of food intake in both in the DHD and in the placebo rat. So both groups, the food intake went down significantly. So they almost ate just 3 grams of food the first day after injection, the second day after injection. But look how the food intake goes up with time. And it really gets close to the DHD group in the rat that's the liraglutide, the rat with DHD that receive liraglutide, but remains significantly lower in the control group. So I usually tell patients when you get your shot, be careful the next 3 days after the shot. You are not going to feel hungry. Don't eat it, because if you eat, you may get sick due to the slow gut motility that this drug causes. So this is the cumulative food intake. So high in the PCOS model, less in the control group. Both groups ate less with the GLP-1 agonist. So this is the body weight in our model. It almost goes to 500 with time. So as I said, these rats, they just keep growing with DHD. Both group ate less. In both group, we see a decrease in body weight. So this is a decrease in body weight in the control group. So the body weight went down. The body weight went down in the DHD, and the percentage was the same in the control in the DHD. And I'm gonna show you why this is important. We measure other parameters. They have insulin resistance, as we discussed, and GLP-1 are very effective in improving their insulin sensitivity. So GLP-1 could be the agent to improve insulin sensitivity in women with PCOS. The increases in leptin went down with liraglutide. The high level of cholesterol went down with liraglutide, and the bad cholesterol went down with liraglutide. And this effect, we only saw it in those rats that received DHD. I mentioned about the decrease in body weight, but the portion of body weight that went down is different. So this is a body weight elevated in PCOS. As I said, they both lose weight, the control and the PCOS. We only saw a decrease in the abdominal circumference, which is a marker of visceral adiposity in the PCOS. We didn't see this effect in the control group. So fat mass is elevated in our model, and look at this. So the delta change in fat mass was significantly larger in the PCOS compared to the placebo. So it's really changes in the lean mass that were more pronounced in the placebo compared to the PCOS. So although they both lose weight, in the PCOS, they lose what we want to decrease, which is the adipose tissue. And the weight loss in the placebo seems to be mediated by lean mass. And this is something that we need to further study. And is an area of exciting research right now, GLP-1 and body composition. Finally, the blood pressure data show that administration of liraglutide, this is very well known that the blood pressure goes up after an acute administration of liraglutide, but with time, the blood pressure will go down. And we only saw that in the placebo. We didn't see any effect in the blood pressure with liraglutide, suggesting that liraglutide will be good for some of the cardiometabolic complication of the syndrome, but will not affect their blood pressure. And this decrease in blood pressure is about 5 millimeters of mercury. So that's what we see in clinical trials with GLP-1 agonists. So what about in the clinic? So I want to share with you a case with PCOS. So she came to see us, and in the initial visit, she had the diagnosis of PCOS. Her glucose was elevated 199. Her liver enzyme were high. Again, this is from EPIC that tell you what is the abnormal thing. So we see high level of liver enzyme. Her A1C, which is what we use in the clinic to diagnose diabetes, was also elevated, and she have profound dyslipidemia. Look the level of her triglycerides, almost 500. When it gets to 500, the risk of pancreatitis is significantly increased. And this was her BMI. 61, obesity more than 30. So these were her characteristics before GLP-1. And look what happened 5 months after GLP-1 administration. So her glucose went from 199 to 87, normal glucose level, normal liver enzyme. A1C from 9.4 dropped to 5.1. And believe me, this is a major drop on A1C, and it's really amazing to see with only one agent. So significant drop or improvement in her A1C. And look at her dyslipidemia as we saw in our model of PCOS. Look, her triglycerides were from almost 500 to just 78. So complete normal metabolic panel, and her BMI was still, she lost some weight, but her BMI was still significantly elevated, way far from what we use the cutoff for obesity. So what can be the explanation that GLP-1 works so well in women with PCOS? So this is data from a paper that was published some years now, and they measured GLP-1 after women with PCOS were challenged with an with a mixed meal test, which is a combination of glucose and high fat meal. So what they saw is that compared to the control group, women who have PCOS actually have lower level of GLP-1. And this is the GLP-1 level on women who have gestational diabetes. So gestational diabetes, they have high level of GLP-1. So they have more insulin resistant, and this could be a compensatory mechanism during pregnancy. But they didn't see that in women with PCOS. So GLP-1 could be a case of hormone replacement in women with PCOS, right? Because they have low level of GLP-1, and then we have to replace their hormones as we do with other cases of low level of hormones. The decrease in GLP-1, we also see it in our animal model of PCOS, and currently we are conducting more experiments to fully elucidate the role of the GLP-1 agonists in our model of PCOS. Finally, I spent the last 40 minutes or so talking about the why adipose tissue. I want to share just one slide that was recently published by my research partner, Dr. Romero and Dr. Rest, that using the mice model, which it have the same cardiometabolic complications that the rat do, they saw that the body weight goes up, the lean mass goes up with DHD. They have an expansion of the fat mass. But look what happened with the energy expenditure. So I told you that when women with PCOS gain weight, it's very hard for them to lose it. So perhaps this is the explanation. They really have a lower level of energy expenditure compared to the placebo due to the DHD. But not only that, look at their activity. So DHD causes a decrease in the level of locomotor activity in the DHD, and also they sleep more. So the rat that receive DHD, they move less and they sleep more. So perhaps this could be some of the explanation why it's so difficult to lose weight in women with PCOS. So to summarize this part of my talk, I show you the calorie restriction by limiting the food intake, abolish the increases in blood pressure, but not the insulin resistant. The GLP-1 agonists improve insulin resistance, but in other metabolic disturbance in PCOS, And androgens mediate the expansion of adipose tissue, white and as well as brown in the animal model of PCOS. Finally, I want to give you just a little glimpse of our data with women with PCOS. So we analyzed Savannah, a medical student in my lab, analyzed the cardiometabolic complications in women that came to UMC to seek medical advice, and she divided the group by race. So women's, African American women who have the diagnosis of PCOS have higher BMI compared to the white. Um, but look at the BMI. So in both group, in Caucasians or white women's, the BMI was way above 30. So obesity is a big problem for both, but especially for African American. We also saw worsened cardiometabolic complications that are associated with obesity in African Americans. So African American women have higher blood pressure, and they'll also have higher A1C compared to the Caucasians. So what could be the underlying mechanism of this worse cardiometabolic complication in African American? So we analyzed the level of free androgens, and we found that the free level of androgens in African American were significantly higher compared to the Caucasians. So this could be the biological explanation why African American women suffer from more cardiometabolic complications compared to white. But is this the entire reason of? Perhaps not. So almost 2 years ago now, we published in the Endocrine Society a policy perspective about racism in endocrinology. And as happened with many things in my research, I learned a lot writing this paper. And I really got stuck with a piece of research that showed that factors that come from the society play a major role in the health outcome that we see in our patient. Around 50% of things that we see, the outcomes that we see in our patients, they seem to be estimated that are mediated by changes in the society. So this was sort of like enlightened moment for me. I spent several years working on protein, genes expression, enzyme activities. But when I saw this number, I thought I want to get busy with studying these factors that could implicate the cardiovascular disease that we see in women with PCOS. So we are studying social determinant of health. These are the list of social determinant of health or factors that play a role in the society, and it really could be one of the mechanisms by which these women with African American women do worse than white women with PCOS. So is there education, the food insecurity, really an extensive list. So we were recently funded to study the cardiometabolic complications in Black women with PCOS. And we are going to study the biology in this group, but also we want to study social determinant of health to see if this the high level of androgens that they have is really the biological mediator of their cardiovascular disease that they have. So our grant have 3 aims. So aim number 1 will measure our favorite hormone, androgens. Aim number 2, we will measure several components of the body composition by bioelectrical impedance. I'm going to explain you a little bit what is this. We're going to measure blood pressure. We are going to do something that we very rarely do in the clinic, which is to measure the waist hip circumference, and we are going to measure the component of the renin-angiotensin system. So this is one of the blood pressure of one of our participants. So we measure the blood pressure in 3 different opportunities with 5 minutes of interval. So you can see that her blood pressure was 148/93, and then kind of went down with time and as the time go by. So this increase in blood pressure is very hard to see it in the office, right? Like our model of PCOS, they have an increase in blood pressure, but it's just a little increase in blood pressure. So it's very hard to measure this this increase in blood pressure in the clinic. So we recently got funded to study more the increases in blood pressure in women with PCOS. So we are going to measure the blood pressure using the ambulatory blood pressure monitor, which measure the blood pressure in 24 hours as well, and compared to the one that we got in the office. And this is my last piece of research. This is the body composition by bioelectrical impedance. So you can measure body composition in the clinic. It doesn't use radiation. For example, this is one of our participants that her BMI is 52, and then you can see the composition of the lean mass and also adipose tissue. So in her case, she had her BMI is 52, 50 pounds, the body fat mass, and 92 are the lean. So we have the opportunity with this device to measure not only body composition at baseline, we also can perform interventions such as GLP-1 and monitor the changes in the food intake. So what we are going to do with our patients, so this is what we did, and I hope you agree with me. So for her blood pressure, we put her on a RAS blocker. We discussed with her the phytotoxic effect, and that she needs to alert us if she have any change for any plans for pregnancy. And for her obesity, we put her on GLP-1, and we discuss the GI side effect and also how we're going to give the drug. To summarize my talk, I shared with you today that high level of androgens are associated with negative things in the cardiometabolic system in women with PCOS. And this is the slide that I always have in mind when I see a patient in the clinic who suffer from PCOS. If they have increases in blood pressure, these are my two systems to go. If they have insulin resistance, adiponectin is something that we are working on it, and it seems to be very promising to treat insulin resistance in women with PCOS. Obesity, I think about GLP-1. I take a lot of time to explain them our finding in the clinic, to let them know that this is not really because they eat bad, it's really because they have an excess of androgens that we don't have a good way to treat, and it's really hard to lose weight. And finally, I also have in mind that high level of androgens may promote renal injury in this population. With this, I want to end my talk. I really want to thank you that you took time of your busy schedule to be here with me this morning. And I also want to thank all my team here in UMC as well as outside UMC. Without their help, I wouldn't be here today. So with this, thank you so much again. Thank you to APS and this amazing research initiative about woman health, and as well as the initiative advisor. And with that, I'm going to end my presentation. Thank you again for being here, and I'm more than glad to take any question that you may have. Thank you.
Thank you so much, Licy. I'm going to give you a second to catch your breath here and just launch our survey pop-out for anyone who needs to leave. We appreciate you being here, and we would love to get your feedback on our survey, but we hope that you can stay because I am going to be doing a live Q&A session with Licy right now. Okay. Licy, there you are.
I'm ready.
Thank you so much for your presentation. It was absolutely fantastic. So much great data. And we do have quite a few questions. I'm going to encourage the audience to continue to submit questions. Even if we don't get to them to live, I'll pass them along to Licy. Okay, first question here. Amazing seminar. Thank you. Do you know if enalapril treatment rescues normal reproductive function in the PCOS rat model?
That's a great question. Unfortunately, we don't have a lot of data with the ovarian pathology. What we see is actually an atrophy of the ovary with DHT, and we just haven't looked at the ovaries in those rats that receive enalapril. That's a great question.
Okay. The next question here is, I'm assuming they mean the birth control pill. Can the birth control pill be used as a treatment?
That's correct. So yes, thank you for the question. So birth control are very frequently used in women with PCOS to regulate their cycle. So there are different formulations of birth control, estrogen and progesterone. We have no data that show that these birth control have any beneficial effect in the cardiometabolic complication. Is something we have some data that suggests that OCP or birth control can actually exacerbate their insulin resistance. So no beneficial effect, perhaps some deleterious effect, very frequently used in women with PCOS to treat their irregular menses.
Okay, thank you. Another question here. Have you considered using a blood pressure monitor that can measure central aortic blood pressure and do pulse wave analysis? Pulse wave analysis will let you measure and see the physiologic difference between people with the same upper arm cuff blood pressure, which may help in the diagnosis of PCOS.
Yeah, that's a great suggestion. I haven't think about it, but yeah, I think it's a great point.
Okay, another question here. Will dual analogs such as tirzepatide
Mm.
give even more than GLP-1 analogs a better prognosis in cases of PCOS?
Such a great question. So that's one of the questions that we have and that we're going to test with our animal model. The clinical data show that actually the dual agonists do work better than the single agonist. So we see weight loss up to 22% with the dual agonist compared with just GLP-1 agonists. So we don't know if that is the case in our animal model. I do have several patients in the clinic that are getting the set bound or the dual GLP-1 Wegovy, and then they have a dramatic weight loss. It seems to be even bigger than the GLP-1 monoagonist, but yeah, that's not the data that is available yet.
Okay, if you have time, I'm going to do a few more questions here.
Absolutely, yes.
Okay, thanks for the interesting talk. Do you know if genes are implicated in the cardiometabolic complications of PCOS, for example, the GATA4 gene?
I don't recall that gene, but I do know that there are several GWAS studies now that are published that show some genetic linkage with cardiometabolic complication of PCOS. So they are available. There are even meta-analysis now with GWAS study. I don't recall that gene in particularly, but it may be there.
Okay.
Let's check it out.
Okay, awesome. I'll pass that question along to you and you can chat with that person if
Yes,
you want.
please.
Okay, I think I'm going to make this the last question, just for time purposes. In the GLP-1 case study with the original BMI of over 60 that you mentioned, do you think that the new normal glucose levels were from changes in diet due to the level that they were eating? Or is it insulin sensitivity that's changing those glucose levels?
Such a great question, right? So, what I think is that women with PCOS have a low level of GLP-1, as it was shown already. So, what we do in the clinic, we do an hormone replacement, right? So, we give them more GLP-1, and then GLP-1 it could be the action in the adipose tissue. So, we have data that GLP-1 are really beneficial in the white adipose tissue. We are going to study the brown adipose tissue, right? It could be the effect of GLP-1 on the brown adipose tissue that makes things so wonderful, but really remarkable effect of GLP-1 in women with PCOS.
Fantastic. Thank you so much for being here today, for your amazing presentation, all of your work, and also your insights in the Q&A. It was a pleasure to have you, and I hope that you had fun.
I did. And thank you so much, Sarah, and all of you again. Really appreciate it.
Okay, and I also want to thank the live audience. We know you have really busy schedules, so we really appreciate you being here live. We also are continuing this series next year. Our next event is on Wednesday, January 22nd at 11 a.m. Eastern Time. You will receive a reminder email with a link to log in, so make sure that you block that off in your calendars. A reminder that the recording of today's event will be available soon, so keep an eye out for an email giving you access to that. And additionally, that survey will appear again at the end of this webinar. We do read all of your comments, so please share share on your experience today. And you can also tell us what webinar topics you'd like to see in the future. And lastly, if you still have questions for Licy, you can submit them now in the Q&A or also in the survey when the webinar ends. In closing, we hope that you enjoyed this Inside Scientific webinar produced in partnership with the American Physiological Society, and we will see you next year. Bye, everyone.